let's do the best we can under the circumstances until the world comes to a more equitable place, because we cannot have a peaceful, kind, loving world with this much inequity. There'll always be strife and wars and going on everywhere in the world when there is this much inequity. They get richer. Everybody gets richer. And what makes ECHO work is love and respect and kindness and empathy and community building. I was hungry for more impact. I wanted to give back to the world. So not everybody is interested in fame, or they may be interested in fame and money and all of that, but they also want to do, if they are Muslims, they want to do zakat. If they are Christians, they want to do tithing. If they are Hindus, they want to do seva.
I know in Ghana, where I come from, there are a few oncologists. There are about 4 or 6 oncologists in the country. So the ECHO model is what we can use to effectively utilize the few specialists that we have in cancer care in Africa. If we know that majority of patients in Africa are diagnosed in late stages with cancer, and effective palliative care like pain control, psychosocial management of the patient plays a very effective role. Most cancers in Africa are diagnosed very late. However, there are few radiotherapy centers in South Africa and also in the rest of Africa. In our province, our patients were being sent to another province for radiotherapy treatment. So what we did, we formed partnership with the private sector which had linear accelerator. So we formed partnership with them to be able to use their machines to treat our patients.
Yeah, my name is Sanjeev Arora. I'm a gastroenterologist by profession. I serve as a professor at the University of New Mexico in the United States, and also the founder of the ECHO project. And at this point, I direct the ECHO Institute in the University of New Mexico.
Impressive. So let's talk about the ECHO project journey. What necessitated what gap were you trying to fill that said, okay, this is what we should do?
So in 2001, I was seeing a patient in my clinic at the University of New Mexico, and she was 43 years old, and in the room with her was a 14-year-old boy and a 9-year-old girl. And I asked her, how can I help you? She said, I have hepatitis C and I want treatment. So I said, of course we'll do that. How long have you had hepatitis C? And she said, I've had it for 8 years. So my next question was, why did you not come earlier for treatment? And she said she lives 200 miles away from the university. She lived in a rural area of New Mexico. She had called my nurse. There was an 8-month wait to see me. And so I said, yeah, there was an 8-month wait, but now it's 8 years. Why did you not come? She said, I'm a single mother and I could not afford to take so much time off work to travel all the way. And your nurse had said I would have to make 12 trips while getting this chemotherapy-like treatment of weekly injections and pills. So she said, I chose not to get treatment. So I said, why did you come today? And she said, I'm having pain here in the right upper side of my abdomen. I did an ultrasound and she had a cancer of the liver halfway between a golf ball and a tennis ball. It was too late and she passed away 6 months later, leaving these 2 children. And I was saying, why did she die of a disease that I knew how to treat? And the answer I got was she died because the right knowledge didn't exist at the right place at the right time, and she didn't have the ability to get to the right knowledge. So the challenge I was facing was there were 28,000 hepatitis C patients who had been diagnosed in New Mexico. This is a reportable disease in the UK and in the United States. We had their names, but only 1,500 had been treated, and they did not have specialty access because there were no specialists in rural areas. So I wanted to bring access to treatment to everybody. So I developed the ECHO model in 2003 to democratize the implementation of my expertise all over New Mexico. And the ECHO model is based on 4 key ideas. The first is to use technology to leverage expertise. In this case, there was no Zoom at that time. So I purchased a used telecommunication bridge, basically, and put it in the basement and created something like a Zoom, but only for about 25 people or so. But it looked just like Zoom. And I said I would share my knowledge this way with primary care clinicians. The next step was what is called sharing best practices. So I went around the state of New Mexico It's a very large state. And I talked to primary care clinicians and told them, look, patients are dying in your community. Somebody here needs to step up to treat them. And I gave them the protocol and lectures, but they said, no, we can't do this. This is like chemotherapy. We are primary care clinicians. So I asked myself, how did you become an expert in treating hepatitis C? I was not born that way. So I did my fellowship in gastroenterology in Boston, Massachusetts. I would see a patient, present to my professor. I would see another one, present to my professor. I did this week after week. 2 years later, they said, you're a gastroenterologist. I said, aha, I'm going to use this case-based learning methodology to create new hepatitis C experts without them doing residency or fellowships. And the fourth principle was to track outcomes. So in 2003, I started my first echo session, which just looks like a Zoom conference. And all 21 of these primary care clinicians would join. And first Paul would present a patient, then Nancy would present a patient, then John would present a patient, all to each other, always at a fixed time, Wednesday at 3 p.m. We would discuss 7-8 patients without their names, and 15 minutes I'd give them a lecture. As I did this week after week, what I found was, in 1 year, they became experts. In 18 months, the wait in my clinic had gone down to 2 weeks, and what we call force multiplication had occurred now. Anybody could get access to treatment within 2 weeks. And the way they were learning, we called a learning loop. They were learning from our lectures, they were learning from our advice on their cases, they were learning by doing, and they were learning from each other because they brought one patient to the network every week, but they may learn on 8. And they became experts. So we started doing research and we found that Echo was producing joy of work for them. It was reducing their professional isolation. It was increasing their professional satisfaction. And most importantly, their self-efficacy went through the roof. As we published all this data in some of the leading medical journals, there was one unanswered question. Can they provide care as safe and effectively as university experts? So we got a US government grant and did a head-to-head study and demonstrated in the New England Journal of Medicine, where we published our paper, a journal you're clearly familiar with, where we demonstrated that these rural clinicians and prison clinicians, primary care, could get the same outcomes as us at the university giving this chemotherapy regimen if they were participating in ECHO through this guided practice model, all teach, all learn. As soon as this paper came out, I started getting emails from all over the world. We realized that 6 billion people in the world don't have access to the right knowledge at the right place at the right time. Without the right knowledge, you can't get the right care. It's impossible. And the challenge was greatest in countries like India, Pakistan, Bangladesh, and the entire African continent, low-income countries in Latin America. I mean, this was a huge problem in Southeast Asia. So we said, okay, we have stumbled on a model which can dramatically, 10 times or more, expand access to best practice treatment. We knew if you could give chemotherapy in a rural area, we could do pretty much anything. And so we started rolling it out in India for TB, in Africa, across the continent for HIV and TB. And then later on, it expanded to mental health disorders and to diabetes and addiction disorders, chronic headaches and neurologic disorders, and got into the cancer field because we realized that cancer was one of the greatest disparities. Women in Africa were dying of breast cancer at much higher rates than anywhere else in the world, even though they had amazing world-class surgeons there. So what was the challenge? It was being diagnosed too late. So we started training a workforce. And if we don't have doctors in HIV, we train nurses to treat HIV with extraordinary results, and community health workers and whoever could be upskilled with this knowledge network or what we call mentorship network. And the idea of ECHO was to democratize specialty expertise, but we realized that in order to really help billions in the world, we had to democratize how to do ECHO. So in 2013, I met with Eric Vaughan, who is the founder of Zoom. And I told him, look, I want to help 1 billion people, but I can't do it without your help, because in Africa and rural India and all, they cannot afford Zoom. At that time, Zoom was not a well-known company. People were only talking Skype. But he gave me a global license, which then I gave away to every country in Africa, to every state in India, and gave away thousands and thousands of. But then one other thing was needed, a technology platform to track everything that was going on with ECHO all over the world and to put an improvement feedback loop on it, so that every echo session was a needs assessment and an evaluation going on of impact. So we spent several $1 million and basically created this technology platform called iEcho and embedded Zoom inside it. So now this tracks the learning journey of every learner in the world automatically. Very much like Amazon tracks your shopping experience, it offers digital certification. It is a resource library of lots of content from all over the world. We first trained University of Washington, then University of Chicago, then we trained one of the Harvard hospitals. We trained MD Anderson in Texas, Memorial Sloan Kettering was trained by them, Dana-Farber Cancer Institute, and a lot of the major cancer centers in the United States adopted it. But our major goal was the global south. So we started training universities all over India, all over Africa, and subsequently ministries of health to help them achieve their mission with speed, scale, higher quality, and lower cost. So for example, the Ministry of Health in Kenya just published data showing that their cost of training a primary care clinician went down from $820 to $21, and it was more effective in Western Kenya. Why? Because previously they had to travel for 4-5 days to Nairobi, then go back, and often they forgot what they had learned. Ours is the drip irrigation method of training, whereas the traditional training methods are that, you water your garden for 5 days once a year, and then you hope flowers will grow all year round, and it doesn't happen. And ours is a guided practice model. It's an implementation model. It's not a knowledge sharing model alone. So it's more effective. And so, but it's much less expensive. And so 20 ministries of health now in Africa have signed collaborative agreements with us. More than 10 in Latin America, every state in India, 28 states, all union territories, the central government in India. So gradually, ministries of health and academic centers, not-for-profits like the American Cancer Society or ASCO, American Society of Clinical Oncology, they all became partners because they realized that democratizing expertise can change the world, because the physics of knowledge is such that it grows with sharing. It's not like money, which is like a material resource. When you share it, you're left with half. But this grows through what we call all teach, all learn, because experts have evidence-based knowledge, the kind you publish in Lancet Oncology. But evidence-based knowledge is just not good enough. You need to adapt it to the social, cultural, economic context and constraints in countries, in localities, their culture. So in an all teach, all learn platform, this adaptation of echo occurs, echo leads to the adaptation of these best practices to local context. So it creates contextually relevant solutions. And the specialists learn from these learners because they have unique expertise in the local circumstances. So all of this, now we have 647 peer-reviewed publications showing that echo is probably the best capacity building model in the world to produce equity. And it is being adopted globally. It's a hub and spoke model. So every university like MD Anderson is a hub. We have 1,370 hubs in the world. We have close to 7,000 networks. We have 2 million unique learners in 209 countries and areas and territories. And we have impacted the health of approximately 300 million people. But we have a long way to go, because as I said, 6 billion people don't have. So we are really interested in partnerships with academic centers all over the world, partnership with every Ministry of Health, partnership with all non-government agencies or organizations that want to amplify their work, like the World Health Organization is our partner. Similarly, the US government CDC is our partner, and so on. But much work needs to be done still. We work in 100 different disease areas, but cancer is a big focus area for us, and 17% of our networks are in either prevention of cancer, like smoking cessation, HPV vaccination, or hepatitis B vaccination, or hepatitis C treatment. We have echoes in early diagnosis, breast cancer, cervical cancer, colorectal cancer, skin cancer. We have echoes related to cancer genetics, teaching primary care doctors and oncologists on the genetics of cancer. We have echoes on treatment of cancer, training doctors to treat with best practices, but also training oncology nurses in Africa, we do a lot of that work to train regular nurses to give chemotherapy, for example. We have echoes in survivorship, because people come to Nairobi or they go to Cape Town and get treatment for cancer. Then they go to rural South Africa. There's no one to do survivorship care there. Nobody knows what to do with the breast cancer patient who's been cured. What screening should be done? What should happen? We have echoes in palliative care, one of our largest, because only 1% of people in Africa actually have access to palliative care. So we are dealing with the entire continuum of cancer, and we want to change the world.
Impressive. You really took your time, and I think it's a fascinating story that you shared. I have a question regarding how these professional associations are reacting. For instance, you seem to be creating like a medical college, a medical school. So how are they adapting to this?
So most, you're making a really good point, right? Knowledge is power. Knowledge is money. Knowledge is fame. But one of the things, so not every specialist in the world wants to democratize their expertise. And that's implied in your question. But there is a whole different type of person in the world. They are also specialists, but they think in a slightly different way. I'm a super specialist, okay? But I was saying, look, the only people in the world I can really help are the people I see myself. The people I can only train are the people I can train myself. And I said, you're going to die. You're going to retire. Everything you've learned over 35, 40 years will go out of circulation. I was hungry for more impact. I wanted to give back to the world. So not everybody is interested in fame, or they may be interested in fame and money and all of that, but they also want to do, if they are Muslims, they want to do zakat. If they are Christians, they want to do tithing. If they are Hindus, they want to do seva. They realize that these people, oncologists, have received so much. It wasn't like they struck the birth lottery. They were born in a family where they got a good education. Many people realize it's not just their own effort. They were lucky. They want to give back. What echoes value proposition to those people is we will let you have 100 times more impact than you can otherwise have. And we will give you the echo model, the software, the Zoom licenses, and 3 days of training free to democratize your expertise. But you're right. If that's not a goal, if their primary goal in life is financial or fame or power, they're not going to do echo. But I don't need everybody. If I have 20 oncologists in a town, city, if I get one of them to democratize echo, game over. You see? Game over, because I'll multiply them again and again and again. So that's how echo works. In this world, people have very diverse motives, okay? You're obviously a very good writer, okay? You could do many, many things with your talent, but you've chosen to work for Lancet Oncology. That's a form of service, right?
Absolutely. Then looking at the problems that they're highlighting at this conference, I know there are lots of questions and concerns around equity, inequality, and all of that. How do you think ECHO plugs in to solve some of these big problems?
So ECHO has only one purpose in life, okay? It's to produce equity. I've always believed that persisting with such inequity in the world, where there are people, take pediatric cancer, 85% of all children in Africa with pediatric cancer die. In the United States, more than 80%, almost 90% live. Is that fair? It's not fair. Yeah, some of these medicines for pediatric cancer that are available in the UK, US are very expensive. Maybe we can't get them all there. But there are generic medicines that we can take to Africa, which are inexpensive. And if we train the workforce, we may not be able to get to 80%. But if we get to 65%, we will save many, many lives. So I don't like to make the perfect the enemy of the good. But I'm saying, let's do the best we can under the circumstances until the world comes to a more equitable place, because we cannot have a peaceful, kind, loving world with this much inequity. There'll always be strife and wars and going on everywhere in the world when there is this much inequity. Logic is, you have to train people on the art of sharing and giving. ECHO is the best training ground. You know why? Because when they give their expertise, they don't get poorer. they get richer. Everybody gets richer. And what makes ECHO work is love and respect and kindness and empathy and community building. It builds understanding through these networks that we create. They're intimate networks. There may be 25 primary care clinicians being mentored by a Daniel Osefi and so on and so forth. So I think that that's our purpose in life. The other thing to remember is that a lot of the Western world works on treatment. That's where the money is. But the biggest impact in the world is done by prevention. Smoking cessation experts in every town in South Africa. Girl and boy is vaccinated with HPV vaccination, which is becoming generic. So you can see a rethink, training community health workers so they can have in communication skills, the kind you have, on how to have conversations with mothers in Nigeria so that they're not afraid of the vaccine for HPV vaccination because they have had a bad experience with vaccine in the past. So all of this there is some really low-hanging fruit which can be done with almost no money if we rethink equity, if we say the purpose is to save lives, and that's what we try and do.
My name is Dr. Daniel Jose Fofi. I am currently working at Kimberley Hospital in South Africa, and we have adopted the Project ECHO model to address the disparities and inequities in cancer care in South Africa.
So let's talk about the problem. Give me a description of what the problem is and how you decided to think, okay, this is what we think will ever solve the problem.
Thank you very much. The Northern Cape province of South Africa is the largest province in South Africa. It has an area of about 370,000 square kilometers. However, it has the least resources for cancer care. In the past, there was indiscriminate mining of asbestos in the province without proper protection of the miners and their family. Even though asbestos mining was banned in 2002, there are still mine dams in some villages. Some of them, even there are schools that are close to those mine dams, and therefore there is continuous exposure of people to those mine dams, asbestos coming from those mine dams. And because of that, there is high incidence of mesothelioma, which is cancer covering the lung and lung cancers. In addition to this, there are also other cancers like breast cancer, cervical cancers in women, prostate cancers in men. Most of these cancers were diagnosed in late stages. Also, as I said, Northern Cape has a very wide area and patients had to travel for very long distances to come and access cancer care in the tertiary hospital. So we needed a model, innovative model to address these challenges in the province. Also in South Africa, there is huge inequalities and inequities in cancer care and also other health care because of the previous apartheid system. The province where I work is an underserved and underprivileged community with few resources, and therefore we needed an innovative model to address these disparities, to address the late presentations, because in that province there was also high amount of tuberculosis and there was misdiagnosis of mesothelioma and lung cancer as pulmonary tuberculosis. Patient who had cough, chest pain, fever, night sweats, they would treat the patient as tuberculosis because the symptoms were similar to lung cancer. So they would treat them with TB drugs for 6 months, and when they don't get better, that is the time they think of lung cancer or mesothelioma and refer those patients. So we needed an innovative model to address the disparities, to address the there was also long waiting periods to address that, and also to address late diagnosis, late presentation, high mortalities. And that was why we adopted the Project ECHO model.
Yes, so how does the Project ECHO model work at the moment?
Well, at the moment, initially we started with lung cancer and mesothelioma echo. But now, because we are also having a lot of cases of breast cancer, cervical cancer, prostate cancer, colorectal cancers, we have extended it to include all the other cancers. In addition to that, one of our neighboring countries, Lesotho, they didn't have their own chemotherapy treatment. They didn't have their own chemotherapy treatment unit, and they were sending patients all the way to India, patients who were diagnosed with cancer, breast cancer, to go for treatment, chemotherapy in India. So we used this Project ECHO to assist them to set their own unit in Lesotho, and because of that, they no longer sending patients to India for chemotherapy. They treat them closer to home in Lesotho. The patients who need radiation therapy, they send them to South Africa for treatment. How we are running this Project ECHO, we run weekly ECHO clinics. Also, as I said, we do have problems with late detection of cancers. So what we have done, we have set up an early detection and prevention ECHO. We're running this ECHO clinic once a month with the Cancer Association of South Africa, and our participants or spokesites include nurses and the community health workers in the clinics, and also doctors in the peripheral clinics in the rural underserved areas. And what we are doing is there is a curriculum that is running the whole year, discussing all the various cancers. We started with cervical cancer, uterine cancer, discussing the early signs and symptoms of treatment and early prevention, how to use this HPV vaccination to prevent cervical cancer. In fact, in South Africa, we are doing this HPV vaccination of young girls from the age of 9 and up to about 14, 15 years for the prevention of cervical cancer. In addition to that, we also, in South Africa, we have, because of the previous apartheid system, there's two healthcare systems in South Africa. There's a private sector and the public sector, and most of the doctors are in the private sector. So what we have done is we're using this Project ECHO to be able to educate the doctors in the private sector in early cancer detection. So what we are doing, we're running once a month at ECHO clinics, and because they are busy, we decided to run it on Saturdays in the morning at 9 o'clock. So some of the private doctors do join, and also the public sector doctors and nurses. It's our discussions, there are case presentations and didactic presentations, and those presentations, those ECHO clinics carry CPD points, just to encourage the doctors to attend, because in South Africa, every year you have to get 30 CPD points to be able to continue to be registered as a doctor. In addition to that, hematology is also there are lots of disparities in hematology. We don't have many clinical hematologists in South Africa and also the rest of Africa. So there is what you call a hematology deep dive program that is running, also using telehealth or telemedicine, using the Zoom platform. All the clinical hematologists from the various university academic hospitals take part. There are registrars who take part. It's also to enhance the presentations, cover topics that are needed to train registrars to be able to write and pass the South African College of Medicine hematology exams. So topics are discussed, and the participants, as I said, include registrars or residents, clinical hematology specialists, there are other doctors, oncologists, nurses, and the idea is to be able to discuss these hematological cases, because quite often if patients with leukemia, either acute leukemia or acute leukemia, lymphomas, multiple myelomas, if they are diagnosed late, their survival is very poor, high mortality. So the idea is to be able to identify the early signs of symptoms, refer them to the appropriate hematology units so that the patients can be properly treated. And those that need bone marrow transplants, they can go ahead to select them and do bone marrow transplants. Another problem that we used this ECHO model to address is pediatric oncology, which is also there are scarce pediatric oncologists in the country. So we're also using that reason to try and address that. And another area, patients that quite often people forget about them, gray areas, no one knows where to manage them. are what you call adolescents and young adults with cancers. Quite often when these pediatric oncology patients are cured of their diseases, they grow, become adolescents and young adults, and we need follow-up of those patients. And also, when they are diagnosed with cancer, it is quite difficult for them, because imagine young adults sitting in the same oncology department mixed with adults to receive treatment. So we're using this project ECHO to try and address some of the problems and challenges to see how best we can manage those patients. Another area we also using project ECHO to address is the HIV and AIDS related cancers. HIV incidence was very high in South Africa, but fortunately we have a very effective treatment for patients diagnosed with HIV now. So they are living longer, and therefore some of them are getting HIV-related cancers or AIDS-related cancers. And we are using the ECHO project also to address and manage those patients. In addition, palliative care is also a huge scarcity at effective palliative care. So we've also launched palliative care ECHO. The reason why we're doing that, because majority of people, they think palliative care is only given at the end of life, but adequate palliative care starts right from the beginning of a diagnosis of a patient with cancer or with any chronic disease. So we're also running palliative care ECHO. During the COVID-19, we used the ECHO very effectively to be able to assist us to continue to manage patients. There were patients who were on cancer treatment, but because of the COVID, they couldn't travel to come and receive their treatment, or they couldn't travel to come and for follow-up. So we used the Zoom platform, which was offered free of charge to us by Project ECHO Institute, to follow them up. And also another area is radiation therapy that we're using. In South Africa and in Africa, radiotherapy services are very scarce. Most cancers in Africa or in South Africa and the rest of Africa are diagnosed very late, and therefore radiation therapy plays a very significant role in managing those patients. However, there are few radiotherapy centers in South Africa and also in the rest of Africa. In our province, our patients were being sent to another province for radiotherapy treatment. So what we did, we formed partnership with the private sector, which had linear accelerator. So we formed partnership with them to be able to use their machines to treat our patients. What we do is we have 2 oncologists in our state hospital. We see the patients, we diagnose them, then we use our own CT scan to do what we call the treatment planning scans. And then we send the patients to the private unit to use their linear accelerator to treat the patients. So by doing that, we started in 2019. We've treated over 500 patients, which previously they had to be sent to another province, long distances, and there were long waiting periods. And because of this public-private partnership, we managed to reduce the waiting period, and we also managed to improve access of patients to radiotherapy treatment, also to all this through this project ECHO.
Yeah, thank you very much. I'm curious to know, we have professional societies. This seems to be like creating a training system outside of, let's say, the Hematology Council of Hematology Societies. How are they receiving it, and how are you balancing the perception that probably this could be like an unregulated training model?
In fact, the project ECHO is a well-recognized model of using it to democratize knowledge. It's a learning and sharing. It is accepted all over the world. It is regulated. What we do is we discuss the participants who are participating in the ECHO clinic do discuss cases of patients. However, we do not disclose patients' identity. So we regularly discuss the patients, and there are experts at the hub who discuss the management of the patients using recognized protocols within South Africa and also worldwide accepted protocols to discuss the management. So if we discuss this regularly and frequently, then it gives the participants at the spoke sites, mainly in the district hospitals and clinics, it empowers them and mentor them and give them the opportunity to be able to manage their patients closer to their homes. So it's a recognized training program. It's not something that is done outside of protocols. We use the recognized protocols to do that kind of training.
Okay, probably my second to last question is how do you think we can still localize it much better so that, African countries continue to deal with brain drain in order to maximize the few experts that the continent has? Looking at your own situation, your own region, what can it still be done to make it perform even much better?
Thank you very much. I think at the moment, what we have tried to do is in our region, we have tried to include we have 5 district hospitals. So we have now extended it we have set up spoke sites in all the 5 district hospitals to be able to get more nurses and doctors involved in the Project ECHO training so that we have more people taking care of cancer patients. In addition to that, we have also had partnerships with other provincial hospitals. As I said, the hematology program, it involves all the major academic hospitals in the country. In addition to this, we are also having collaboration with other African countries. There's what we call Africa ECHO that is run monthly. And there are participants from Congo, DRC, from Nigeria, from Kenya, from Malawi that are all joining. It's mainly to address issues of cervical cancer. In Africa, throughout the whole of Africa, we have a lot of cervical cancer cases. A majority of patients are diagnosed very late. So that ECHO is trying to train people for prevention and early detection of cancer, the vaccination, HPV vaccination, and also discuss the early detection methods. So in Africa, we have huge disparity of oncologists. In fact, the whole of South Africa, we have only 250 oncologists, and out of this, only 20% are working for the public sector. The rest are in private practice. And in some other African countries, you may have that a country may have 1 or 2 oncologists. I know in Ghana, where I come from, there are a few oncologists. There are about 4 or 6 oncologists in the country. So the ECHO model is what we can use to effectively utilize the few specialists that we have in cancer care in Africa. If we use the ECHO model, the ecosystem, everyone can sit in his or her own country, present cases, we discuss the cases together, and we will have effective way of managing our patients. And by so doing, we will be able to help to address the scarcity of trained oncologists and trained people in giving cancer care in Africa, and especially in palliative care. We know that majority of patients in Africa are diagnosed in late stages with cancer, and effective palliative care like pain control, psychosocial management of the patient plays a very effective role. And I think the Project ECHO model, which is free of charge, now I think a lot of other African countries are also adopting it because they provide a platform to us free of charge. The only thing is to be able to get internet connectivity. So if we use the project, and we should be able to address most of these disparities and inequities in cancer care in Africa. There are a few challenges of using the ECHO model. One of the main challenges is internet connectivity. There are certain areas that are very difficult for them to zoom in. And also during the ECHO clinic, sometimes the internet is very, very unstable. That is a huge challenge. Another challenge is also, some of the doctors, the experts who may be coming to, participate in the ECHO clinic. Doctors may say they are busy and all that. So what we do is we try to run the clinic at certain times of the day, sometimes around 10 o'clock when it's supposed to be tea time, 4 o'clock when people might have finished most of their work. And also we provide CPD points to encourage them to attend. Yeah, thank you.
Yeah, those are really, really smart folks. So thank you very much. I really enjoyed talking with you, and good luck in everything.